Dr. Cross. Thank you so much for taking the time to join me today, and thank you for the work that you do. It's invaluable. This whole pandemic situation is information overload at the moment. It's moment by moment, it's changing all the time, and I think people are struggling to keep up with what's going on. But fake news, we've got articles coming out all the time, misinformation, so it's great to have you here to iron out a few of the facts. Can you just take me through where we're at with the disease at the moment?
Sure. So thanks for having me, Nikki. In Singapore, we are doing exceptionally well in comparison to some other countries. I think the community transmission is down to an all-time low. And whilst the disease continues in the dormitories, the individuals in the community are less affected by that.
Yes.
We're very, very well protected in Singapore. In terms of treatments for this disease, I think we've had two pieces of good news so far. And that has been that we know that a drug called remdesivir, which is a pharmaceutical drug, we know that it has some efficacy in people who are extremely unwell with the disease in terms of reducing the duration of how long they are unwell for. There was a group in Oxford that discovered that a really very readily available drug, a steroid drug that we use a lot and is very cheap, is actually effective at preventing deaths in people who become very unwell with COVID-19 as well. So I think in comparison to a few months ago, we are certainly somewhere along in terms of discovering a treatment for this, but there is hope on the horizon, I feel.
This started off as a respiratory disease, and I've read information to suggest that it's a vascular illness that affects the cells.
I think the way to best understand this from a scientific perspective is to understand that firstly, viruses are intracellular bugs. They don't exist outside human cells, they exist within them. And they have to have a gateway, a port of entry. We know that this caused primarily a respiratory illness. So either an upper respiratory tract illness, that is you get a sore throat, you might get the sniffles, you might get a bit of a cough. And in some people, it causes a lower respiratory tract illness in terms of getting a pneumonia. It affects the lung tissue itself, not just the nasal pharynx. So I guess primarily, because this is where the largest concentration of ACE2 receptors are, you see mostly this disease causing pathology here, up here in the nasopharynx and then down in the lungs. But ACE2 receptors occur everywhere, in a lot of cells, not everywhere, but certainly in a lot of cells in the body. And we know now, and we are discovering more and more, that this virus can certainly affect a lot of organs. And primarily, I think what the greatest discoveries that have been made so far is the effect on the vascular system. When the endothelial, that means the lining of the blood vessels, which also contain these receptors, so the cells are able to infect endothelial lining. When they get affected, they form blood clots because it gets inflamed. And these blood clots are then what causes a lot of the damage that we find from COVID-19. So yes, it is still considered to be primarily a respiratory illness, but we are discovering more and more that its effects are far more wide-reaching than just respiratory.
Does this help you in terms of treatment, or does it hinder it?
Not really. To be honest, it would be better if it was contained to a single organ for everyone involved. It definitely adds complexity that we don't really know altogether as yet how far-reaching this disease process is. And we worry about it because we worry about it for two reasons. Will we be able to predict someone who comes in with it who doesn't have typical symptoms? They don't have respiratory symptoms, but they come in with a stroke. Are we going to know that this person actually has COVID-19? So that's one reason why I think it's a bit troubling. The second reason is also, if we don't know what its far-reaching effects are we going to be able to help someone who gets impacted by the disease in that certain way? So the more we learn about it, I think the more we are discovering that this is an enemy like no other.
So just to clarify, are the symptoms still upper respiratory, or are there other symptoms that can present?
The majority of patients present with respiratory symptoms, and certainly that is what we as a community have to look out for, is when you get a cold, when you get the sniffles, when you get a sore throat, a cough, when you start getting fevers associated with these symptoms, or just fevers on their own sometimes, like any other influenza type of illness, that's when you should be saying, could I have COVID-19? Should I go get swabbed?
What percentage of people are being reinfected?
The problems with understanding reinfection is that there is no good published data overseas. Even if we have no cases here in Singapore, there's no good published data overseas on what the rate of reinfection is like. So let me give you an example. Whenever we see a publication about reinfection, the authors often talk about, is this a true reinfection, or is this a case where patients have had COVID-19 and it's just come back? So it's not like the virus was cleared from their body and then they've gone out and got it from someone else again. Or is it rather a case of they've always had it in their body and it's resurged, it's come back? So that's called a recurrence of COVID-19. And that is really, really hard to tease out at the moment. Regardless of whether it's a reinfection or recurrence, can it happen? It appears to be that way. However, because the number of cases where this is being described is few, it's a handful of cases every time that's been published about, our general feel is that reinfection or recurrence, whatever you call it, is a rare entity. It's not that common. A caveat to having said that is that we are just 8 months into this process. So it may be that people just haven't had an opportunity yet to get reinfected. And when all these measures that we put in place get lifted, whether we see greater rates of reinfection, then that may play out. The other reason may be that we have, anytime someone gets COVID-19, the majority of people form antibodies to it, and those antibodies last a while, and that protects them. There is contention about how long the antibodies last for, and we believe it lasts for at least a few months. So if you look at it from a Singapore perspective, you know, we had a huge burden of illness really in March and in April, and we're just coming out of 3 months from that now, where community levels are really low. So we may never see reinfections or recurrences like they are experiencing overseas. Here, whether it can occur, it appears to be so. We certainly can see reinfections, and I think it is possible, but we are uncertain as to how many people are truly at risk of reinfection.
And so globally as well, though, like, do some of the other countries have clearer data on this? No, not yet.
That's the problem, Nikki. Even overseas, we haven't really seen any definitive data to suggest that reinfection is a true entity. We've just seen a few reports saying it occurs. I think it's really important for us to act as if reinfection is possible.
Yes,
from a public health. Exactly. So from a public health perspective, we'd be doing so much better, even if we've had COVID-19 once, to believe that we could do it again, because it will mean that we would keep up the measures that protect everyone.
I think it's just because it's in its infancy. We just need more time, or you just need more time to be able to figure it out. So,
well, exactly. If you think about it, this virus is 8 months old.
Yeah.
It's 8 months old. You know, something like HIV is decades old, and we still don't have answers. We still don't have a treatment. I mean, I don't mean to be bleak, but this is early days.
So all the mask wearing and the hand washing and the sanitizing is definitely having a positive effect on reducing the rate.
So we know from scientific data that mask wearing is effective. And I think that the mask wearing story is really incredible. People wore masks in China. At the beginning, even here in Singapore, we chided them a little bit for doing it. We said, that's not necessary, it's overkill. We didn't do it ourselves. But then we got good quality data that said it's helpful. It helps prevent transmission. And the reason it does is because people who spread this disease can have minimal symptoms or can have no symptoms and still be spreading it. Indeed, social distancing is exactly the same.
Yes. So what is the rippling effect of this moving forward on this completely sanitized nation, especially for children, what immunity or ability to ward off other infections and viruses are we going to have?
Yeah. So I think what you're referring to is the dirt theory. So the dirt theory essentially holds that we need a certain level of exposure to bacteria, viruses, fungi, antigens is what we call them, to give our immune system something to do. It's something I worry about myself. You know, I have young kids and I want them to go play in the dirt as much as anybody else. Yes, whilst we are taking all these measures with hand hygiene and with mask wearing, I see them as temporary, effective. This is what we have to do to prevent a disease that is causing so much devastation right here and right now. We've got to do what we need to do to save lives. And there may be some fallout from it. But the price we pay for not doing what we have to do right now, I think is a really high price. It's not something that I'm prepared to pay.
And are children still less likely to get COVID-19?
It appears that way. They're less likely to get COVID-19, the disease. You can have the virus without necessarily becoming unwell with the disease, with COVID-19, the disease. But because we haven't been testing children to the same degree that we've been testing adults, we don't know if there is a huge number of children who are asymptomatic. You could say carriers. In adults, we certainly have seen that when they get it, they are more at risk of becoming unwell with it, and definitely seriously unwell with it.
Well, I'm glad that the children are sheltered to an extent.
Thank goodness. Yeah.
Talk to me about these waves.
Yeah. So
what's going to happen with are we getting, I mean, you may not know, but are we going to be getting more waves?
The possibility of a wave always exists, Nikki. So when borders, even if there's no community transmission in Singapore, should the borders open up in Singapore and we have transmission occurring in countries from which people travel, we could very well see another wave here, which is why it's important at this stage to continue to keep up the measures that we are with social distancing, working from home.
What about different strains?
Yeah. To be honest, virologists at the moment don't actually think that we've got new strains of this virus. Okay. That's not to say that the virus hasn't mutated. It's just that these mutations that have occurred have been inconsequential in those two respects, in terms of transmissibility and in terms of how much destruction it causes. Whilst I say this, I will, bite my tongue, because this disease is evolving very rapidly, and it could well be that a paper comes out tomorrow saying, guys, we've got a new strain. Yeah, this one looks deadly. So we don't know. At this point in time, right now, we don't actually believe that we've got different strains by the definition virologists use.
Why are some people so adversely affected by the illness and others seem to be able to just work through it if there is no underlying or pre-existing condition that would adversely affect it?
So the reason, that is definitely the $1 million question. And this is what people are looking at. We as human beings are very complex in terms of our immune systems. We're all different. We're as different as we look. So our immune systems are as different as we look. Whenever we have exposure to a certain pathogen, we will react differently. And that's sometimes unpredictable. We're not so concerned about people who get this disease who aren't that troubled by it. What we're concerned about is the person who gets it and unpredictably has a really awful outcome from it. That's what we're really concerned about. If we could prevent that from happening or predict that happening, then that would be a solution.
Yes. And what has Singapore done to have such low death rate?
Again, another amazing, important question. I think it's a function of two things. Number one is that Singapore had a largely young population who got infected, and that was unfortunately the dorm workers. So these were able-bodied men, and by function of being here, they were robust, and so they weren't as severely affected as some other countries which had a very large population who were aged. So we had a young, healthy population who primarily became infected. The other thing too to remember is while 50,000 or 51,000 seems like a huge number, it was 51,000 people over 8 months, which is actually quite a flat curve in comparison to other countries that have thousands upon thousands of cases per day. And when that happens at that high rate, when the peak is that high, it overwhelms your health system. And when your health systems are living creatures, when they become overwhelmed, they stop functioning normally. When they stop functioning normally, you're going to see more deaths from something that would otherwise have been preventable. So this is what flattening the curve was about, and this is why it worked in Singapore. And that, I think, had partly to do with why we had the death rate that we did. There are some unknowns, even having reduced, it's not just about the death rate. We also had a smaller number of people end up in ICU. So people are asking questions. Was it something that we did? To be fair, we didn't do anything that different to other people, apart from the fact that our health systems were always structurally and functionally sound.
Yeah, because if the death rate is, if you take out the elderly, you take out the immune compromised, people that have pre-existing conditions, is it something that we can live with and function as societies?
Yeah. And
should we be?
So whilst we could say that we could, if we were to lift restrictions, which would allow our economies to return to health again, the problem is that we need to have health systems in place that could cope with the number of people who get sick. So I think that we really need to ensure that, because otherwise, Nikki, if you have a health system that's overwhelmed, and trust me, we often are, even in normal times, if we come close to the tipping point or beyond, then what happens is that you don't just see deaths from COVID-19, and let's say it's just the old and the infirm who get affected, is that when your road trauma accident comes in, you have no ICU beds, or your doctors and nurses are exhausted, and they just drop the ball. So, if we are going to allow economies to return, we need to make sure that our health system can cope with the fallout of huge numbers of people coming into hospital.
And it also stops people from getting other things, other ailments and conditions looked into to get early detection, because people are just afraid to go to a doctor.
Exactly. And that is something that the medical community is extremely anxious about. Overseas, for example, people presenting for routine HIV care, tuberculosis treatments had dropped off. People just weren't coming. And the unfortunate part is they would die if they didn't come. But COVID-19 meant they couldn't access care, or they didn't want to access care as they could have before. And certainly here in Singapore, we've seen, as a measure some of the hospitals have taken as well, we've seen people not come back for their non-communicable disease treatments. We're going to see the fallout from this virus for a long time to come, just in terms of other health outcomes as well.
Yeah, absolutely. And is that counted anywhere? Is that logged?
I don't know. It's a really good question. I think that, the Ministry of Health here in Singapore and other departments of health elsewhere will certainly have to, or do a retrospective, comparison between now and before to see what the fallout has been. Yeah.
So many questions. The future.
Not a lot of answers.
No, the future's quite unknown. Thank you so much again for your time and all the work that you do, and for answering these pressing questions. And I wish you well, and thank you again.
My pleasure. It was my pleasure. Thanks, Nikki.